Hello everyone. Topic of my presentation for today is treatment of calcified root canals in elderly. As we know that the population of elderly people have been increasing, and it has been estimated that people older than 60 years of age will double by 2050, reaching 347 million people. So, since there is an increase in number of elderly people, there is an increase in number of treatment needs also by them. Endodontic procedures specifically become very challenging in elderly patients because of a lot of reasons. And the first and foremost reason of that being root canal system being calcified or sclerosed. This happens in reaction to the lot of tooth wear which has happened over the years, restorative procedures, vital pulp therapies, regenerative endodontic procedures, leading to hard tissue accumulation within the pulp canal space at a slow rate. This has been termed as calcific metamorphosis or root canal obliteration or pulp canal calcification. Because of this, whenever you attempt an endodontic therapy in such a case, the chances of procedural errors such as access cavity perforations, ledging, missed canals, etc., increases multifold. Calcific metamorphosis appears as an absence of a canal or a very thin canal seen radiographically. However, micro-CT studies have suggested the presence of a narrow canal, whether it is visible on the radiograph or not. Calcific metamorphosis can be of two types: localized obliteration, which is seen in one particular tooth related to trauma, and the prevalence of it ranges from 3.8 to 24%. However, in case of elderly people, because of attrition, generalized wear, repeated restorative procedures, we may see generalized obliteration leading to complete obliteration or a presence of a hairline thin pulp chamber and canals. There are many challenges which we face as endodontists when a case of generalized attrition or an elderly person comes up to our practice asking for a root canal treatment or requiring a root canal treatment. These challenges are pulpal calcifications, heavily restored teeth, periodontal diseases, attrition, abrasion, recession, in fact, communication challenges, complex medical history wherein there is involvement of a lot of systemic complications and medications, postural problems because of osteoarthritis, and in fact, even problems with rubber dam application, which hinders the complete isolation of the root canal space. As we age, there are a lot of changes occurring in our body. Similarly, is the case with pulp canals. The pulp space decreases, the water content of the teeth decreases, pulpal neurons, vascularity, cellularity decreases. However, there is an increase in the predentine layer of elderly people, occlusion of dentinal tubules, increase in cracks and crease lines, pulpal calcifications, cementum deposition, which shifts the minor apical foramen, and increase in collagen fibers also. So, when we talk about the treatment needs related to elderly people, increased tooth retention in elderly people have increased the treatment needs in this industry. But their priorities and their expectations are different from younger patients. Also, for them, the teeth are more related to functionality and diet, as we call it, rather than aesthetics. So increased anxiety and increased emotional needs of the patient are also there, which we have to take care of. However, if we successfully rehabilitate such patients, it has been reported that it results in improved oral health related quality of life. When you talk about diagnostic considerations of calcified teeth, it is important to know that in such cases, because the pulp chamber has constricted or receded, there is decreased dental sensitivity. Patient may directly report to you with painless pulpitis. And when you test them with vitality testing also, dry eyes may not give you a good response. So how do you diagnose So in such cases, electric pulse vitality testers are more of use because the decrease in neural nerve stimulation is not observed as yet. When you talk about radiographic interpretation of the canals, a preoperative radiograph is very helpful and useful before you start an endodontic therapy in such a case, because it tells you about the degree of calcification, it tells you about the size of the pulp chamber, it tells you about the root canal curvature, and sometimes even if the canal is not very visible on the radiograph, it has been observed that the canal still exists, because that is why periapical disease is still there. CBCT has reported lot of studies have been reported with CBCT wherein canal detection has been possible, wherein radiographically those canals were not visible. CBCT also plays an important role because CBCT tells us the exact depth of pulp chamber, and as a clinician, we can use it as a reference point when we are looking for such canals. Now, when we are trying to locate the canal orifice, few of the requisites which are going to help us in giving a successful treatment outcome are preoperative radiograph, definitely, then surgical loops, and if possible, dental operating microscope and rubber dam. Only in cases where you are not so confident that application of rubber dam may cause you misdirection or disorientation and may result in access cavity perforation, that is the only situation wherein you can go ahead and do access cavity preparation, locate your canal orifices without rubber dam. However, once the canal orifices have been located, the rest of the root canal therapy has to be completed under rubber dam isolation. Other few tools which aid us are front surface mirrors, long tapered burr, endo Z burr, ultrasonic tips have become very useful, Munz burr and DG16. So we have to identify where exactly is the depth of pulp chamber, and that depth has to be kept in mind when you are preparing your access cavity. Orientation and reorientation, repeated radiograph taking becomes an essential part of access cavity preparation of such teeth. Please, we should never ignore the visual clues which are related to the calcification, that is differences in color, texture, morphology, translucency of the calcified deposits than the normal dentine. Any areas of discolored tissue have to be probed with DG16 as they may represent a small puncture into the pulp space. So you can see in this picture that once the pulp chamber, once the pulp stone is removed, the canal orifices are clearly visible. Any drop which is seen or which is felt in case of opening of a calcified tooth should ring bells in your ears, because it may indicate a perforation. And the perforation can be confirmed either radiographically or through an electronic apex locator. Once the canal orifice has been located, half of the battle is won, because as we know that calcification is present more coronally than apically. Once the coronal obstruction is removed, usually the instrumentation is easier. But in fact, in case if you still find it difficult because of the fibrous tissue being present in the canals, there are many files which are available to us in the market which help us, such as K files, pathfinders, D finders, C files, and then modified K files. A buckling resistance activation technique has been described, which uses an engine-driven file with an active tip against the calcified tissue that is blocking the canal orifice. And herein the instrument is activated and the file is pushed in an axial direction against the calcification. When the progression of the file is achieved, the file is removed from the canal and the canal patency is established with a hand file. Another concept along with this is your continuous chelation concept. As we know that calcium ions present A major component of the dental canal calcifications, chelating agents are very important when we play a role of access cavity preparations or negotiations of calcified canals. So in continuous chelation concept, we use hypochlorite along with weak chelators such as etidronic acid rather than using EDTA, because continuous use of strong chelators such as EDTA may have decreasing or adverse effect on the mechanical properties of the dentine. So we use hypochlorite along with a weak chelator. In between, we can use strong chelators such as EDTA. So these are few cases wherein the calcified canals have been negotiated successfully with the help of the ultrasonic tips, microscope, surgical loops, and DG16. Sharing few cases along with, and with persistence, determination, perseverance, and patience, these teeth can be treated. So coming back to the guidelines for the treatment of calcified teeth in elderly patients, we have to keep in mind that we give short appointments. We use pillows for their back and neck being in comfortable position. Mouth props and bite blocks for patients who cannot keep their mouth open for a longer time. Magnification and trans-elimination to identify calcified canals. Rotary instrumentation so that we can reduce the treatment time. Care must be taken at the conclusion of the appointment to ensure that orthostatic hypotension should not develop. In the end, I would like to conclude that as long as the tooth is strategically important and can be saved, then endodontic treatment is very much indicated in a healthy and elderly patient. These are my references. Thank you so much.